All right, everyone. I'm excited to introduce our next speaker, Dominic Denning. Dominic Denning is a graduate student in the clinical psychology program at the University of Massachusetts Amherst and a trainee in the clinical affective science laboratory under the mentorship of Dr. Catherine Dixon Gordon. Dominic's program of research is aimed at advancing the understanding of how stigma and interpersonal emotional processes potentiate risk for and maintain suicide and other self-damaging behaviors. He has received numerous awards for his research scholarship, including the Gunderson Young Investigator Award from the North American Society for the Study of Personality Disorders, and the Student Training Award from the Academy of Psychological Clinical Science. Dominic's research has been disseminated in the form of 15 peer-reviewed journal articles and book chapters and over 35 conference presentations. In addition to his research contributions, Dominic serves as the student representative for the Personality and Disorder Special Interest Group at the Association for Behavioral and Cognitive Therapies. Please welcome Dominic to the stand.
Thank you so much for that lovely introduction. No pressure. Thank you all so much for having me today. I'm really excited to get to talk about a topic that's really close to my heart and based on a lot of my clinical experiences with clients, actually. So my topic today is primarily going to focus on borderline personality disorder and sexual and gender minority populations. And because we have so many folks with lived experiences in the audience today, we understand that research is oftentimes a very one-way track thing where we're making a lot of requests of participants and clients to disclose a lot and be vulnerable to us. So I thought it was only right that I start with sort of how I got to study this population as well. Suicide was sort of a recurring theme in my own life growing up. There were many folks around me in my family and friends and peers that were dealing with a variety of suicidal crises. And in high school, I actually had one friend a year die by suicide. So this really was irritating to me. I didn't like this suicide thing that was trying to take things away from me that I really cared a lot about. And so ultimately, I went to undergrad, got a degree in psychology, and worked on an inpatient DBT program for adolescents. Through this experience, I was sort of shocked to find out that about 40% of the clients on the unit at the time that were diagnosed with BPD also identified as a sexual or gender minority. And were oftentimes disclosing to me experiences of stigma within their own families and within their peer groups, as well as from medical staff on the unit. And this really pissed me off. So I decided to get my PhD in clinical psychology, where, as mentioned in the intro, I study a variety of life-threatening behaviors, but particularly in sexual and gender minority populations. So I'm an angry researcher. So the purpose of the talk today is really to highlight the importance of considering various identities in the context of, oh yeah. Can you all hear me now? Okay, great. Identities with borderline personality disorder. And before I jump in, there's a couple key terms that I wanted to just go over that are going to be presented throughout the presentation, as well as some noteworthy limitations that I want to make apparent before we sort of jump into the literature as well. So in terms of what I'll be presenting today, there will be almost exclusively studies related to adults with BPD and sexual minority folks. There has not been a ton of research in the area of borderline personality disorder within sexual minority adolescents. There are 2 or 3 studies out there. So just to streamline things a little bit, I made it a little bit more strict with only including adults in this sample. But in terms of sexual minority populations, what this actually represents are folks that identify as gay, lesbian, bisexual, and other variations that are not heterosexual. We also have gender minority populations that I'm going to be talking about today, and these are folks who identify as transgender, as well as folks that maybe lie outside of the gender binary or the sex binary in this case. So folks that are non-binary, gender expansive, agender, and things like that. And if you see abbreviations of SGM, it's referring to both sexual and or gender minority populations throughout the presentation. So to jump into the content, what does the actual prevalence rate look like for sexual minority populations seeking treatment for borderline personality disorder? And in the review of the literature, about 7 to 58% of clients with BPD identify as a sexual minority. When we average this across studies, we see that about 21% of these folks identify as sexual minorities. So nearly 1 in 5 folks on, a lot of these are on inpatient units, are identifying as a sexual minority with a borderline personality disorder diagnosis. In terms of when we compare sexual minority women to sexual minority men, we actually see that sexual minority men present with BPD more frequently than women. And so just to kind of put this into perspective, right? The US population has about 5.5%, according to a study from the Williams Institute, rate of sexual minority identities in the US. And essentially what we're seeing here is that on inpatient units, they're represented at 4 times the rate. In terms of non-clinical samples, there were a handful of studies from myself, as well as a number of other wonderful authors that have looked at BPD specifically in samples that were exclusively sexual minority adults. And what we found is that actually about 23% of the general community, when we administer screening measures for borderline personality disorder, meet a probable diagnosis for BPD, which is really high. So to put that into perspective, we expect lifetime prevalence of BPD to be around 5%. So in the community, folks are meeting the cutoff scores for a lot of these commonly used BPD measures at 4 times the rate. And we're actually finding that people that do not identify as monosexual, so folks who are gay or lesbian, present with lower rates of BPD actually compared to folks who identify as bisexual or pansexual or other presentations. And there's a lot of variability across these studies, both in the clinical and community samples that I presented thus far. And so I think it's worth noting that for the treatment studies that were done in the clinical samples, these were primarily done in the 80s and 90s, where it probably wasn't super safe to disclose your sexual orientation to your providers at the time. So the rates there might be a little bit rough based on that. And then also in the community sample, we also have a number of limitations due to different sampling methods, different measures that we used that certainly create a vast range of scores than what we're seeing. But keeping this in mind, we also wanted to just present some findings about, well, what are really the symptoms that are driving this prevalence in sexual minority folks? And what we were able to find is that affect lability, emptiness, fears of abandonment, self-harm, and self-image concerns were significantly higher in sexual minority adults compared to, this was a comparison sample of presumably heterosexual college students. And actually they scored lower in terms of impulsivity and quasi-psychotic states compared to the sample, and that there were no differences in terms of anger. However, a study that Dr. Rodriguez-Cejas published a couple of years ago using the NEABPD study, which is about 36,000 participants that were recruited in the US between 2012 and 2013. What he found was very similar to the pattern that I found in terms of 15 of the 18 items that were used to assess BPD were actually significantly higher or more likely to be endorsed by sexual minority participants. However, when we attach more strict criteria to this, what we find is that instead of 15 out of 18 criteria being more likely to be endorsed by sexual minority populations, we actually find that only 4 of them are more likely to be endorsed. And what this is looking at is when we attach functional impairment and distress to these individual items and symptoms, the gap actually narrows between the disparity in terms of endorsement between sexual minority adults and heterosexual adults. And that when we apply different personality aspects to this and other transdiagnostic factors and control for that, we find that really only item 11, which is related to suicide, maintains in this population. So something to think about when we're diagnosing folks with sexual or gender minority identities, really applying strict criteria, because it does really narrow the gap in terms of this disparity here. Consistent with this, when we compare sexual minority men to women, we actually don't really see many differences in terms of these domains of BPD that folks present with. We really only see differences in the cognitive domain, where sexual minority women present with greater symptoms in the cognitive domain. My hypothesis is that this is primarily related to self-image and things like that. Women in the country, we put a lot of pressure on identity-related things and how people present themselves. And it would make a lot of sense that they would score a little bit higher in this cognitive domain. In terms of BPD and gender minority populations, the prevalence rates in the studies that we surveyed, there are only 10 studies looking at this, 1.4 to 52.7% of folks who identify as transgender or gender expansive were meeting criteria for BPD. And averaged across studies, we see it's just under 10%. Now, thinking back to the first slide that I showed you all in terms of treatment settings, I was saying that about 21% of sexual minority folks on units that were treating folks for BPD identified as a sexual minority. And this is a lot lower than that, which seems a little bit unusual. And I think that it warrants some discussion. So when we're talking about how these folks were sampled in these studies, most of them were sampled outside the US, and all of them were receiving gender affirming care during this time. And so we would expect to see lower rates given the salubrious effects of gender affirming care on mental health concerns in folks. We also know that a lot of these folks were going through gender affirming procedures and stuff like that, and criteria associated with BPD, depending on the country or state that you're in, may actually preclude someone from getting gender affirming care. So if folks are expressing a lot of suicidality or non-suicidal self-injury, that actually may not allow them to go through and get a surgery at that point. But even with this sort of funky number, we still see that it's about twice as likely to present even in treatment-seeking populations that are receiving gender-affirming care compared to cisgender adults. And so this sort of begs the question, why are the rates of BPD so high in sexual and gender minority populations? Well, there are a number of reasons why this may be the case. The first thing that Dr. Kamal also referenced was clinician bias. Those of us who are clinicians in the room, we are the problem sometimes. So actually a vignette study that Catherine Eubanks Carter and Marv Goldfried did was sent out to a bunch of APA listservs for clinical psychologists. And they recruited 141 therapists, and they presented them, different vignettes with different constellations of symptoms and also gender identities for the patients, as well as whether or not they were explicitly gay or lesbian, had an unidentified partner, or were explicitly heterosexual. And what they ended up finding was that specifically in folks who were sexual minority men and folks that were male and had an unidentified partner of a certain gender were more likely to be diagnosed with BPD, regardless of what symptoms they were presented with. So they could have been given a case that was like a very clean-cut OCD case, and they were like, nope, borderline personality disorder because they're gay. This was not found in women clients. And interestingly, most therapists were more confident to work with a female client compared to a man, and actually gave them a better prognosis, even though they were diagnosed with BPD compared to men. What's really concerning about this is that about 56% of the therapists in the study provided supervision to clinical trainees. And so there's a lot of opportunity for transmission of bias taking place here. And another 61% provided consultation to other clinicians. So again, like this really is a catastrophic effect that folks can have on how we're diagnosing people from marginalized communities, with also a diagnosis that typically is very stigmatizing. So another thing that could account for this is measurement bias. So we know that common screeners and symptom measures for borderline personality disorder have not been evaluated in sexual and gender minority population. And so it's really critical that moving forward that we use invariance analyses to compare sexual minority populations and gender minority populations to cisgender and heterosexual populations to make sure that our measures are actually performing the same across populations. And to put this into perspective, I ended up writing a paper earlier this year that a commonly used measure, the DERS, the Difficulties in Emotion Regulation Scale, a commonly used outcome measure for folks with BPD, does not perform the same in sexual minority samples, actually. And so therefore, we can't really compare mean score differences between sexual minority folks and heterosexual individuals on these types of measures because they just don't perform the same, even after removing items that did not load well. The third piece that could actually explain why borderline personality disorder is more common in sexual minority and gender minority populations is minority stress. We know that in addition to general stressors that everyone experiences on a daily basis, folks with marginalized identities also experience distal stressors that occur in their environment, such as discrimination, violence, victimization, harassment, and other forms of prejudice. And a lot of times, as Dr. Kamal mentioned, the proximal minority stressors are sort of the after effect of that, where we internalize a lot of these attitudes that folks have towards us about ourselves. And these ultimately lead to poor mental health outcomes for folks that identify as part of a marginalized community. So is BPD actually more prevalent in sexual and gender minority populations? This is a hard question. My thought is that it probably is, but there's a lot of error around this right now and a lot of uncertainty based on a lot of the limitations that we have based on the existing literature. Again, Dr. Sharp presented on dimensional models of personality, and none of these studies have used dimensional models of this. There are folks who are working towards that, Dr. Rodriguez-Sejas and Dr. Eaton, who are looking at how minority stressors affect some of these higher order structures of psychopathology. But this does raise the question, then, how should we conceptualize BPD in sexual and gender minority populations? So we have an existing theory for BPD that I think a lot of us are very familiar with, that folks have some sort of dispositional vulnerability factor related to their emotions or interpersonal relationships and being sensitive to those things. And that when the environment responds in an invalidating way, that this leads to emotion dysregulation, which also gives rise to a variety of other behavioral dysregulation or target behaviors, as well as interpersonal difficulties with folks in their lives. This is a good model, but it can be improved a little bit to be a little bit more consistent with diverse populations. Because again, these were models that were created based off of cisgender, heterosexual white women who were typically educated. So the typical response that we see in terms of invalidation can be seen in the second column from the right, where there's a stimulus that sort of elicits an emotional response from someone in their environment. And the environment ends up ignoring or blocks those needs from being met, which then a person who is receiving the invalidation and experiencing the emotion finds a maladaptive path for getting needs met. So this would be like engaging in a target behavior or suppressing your emotions. And then the emotion is negatively appraised and the person's relationship to that emotion is damaged. This is a very common process that we see in clients with borderline personality disorder. However, this process looks a little bit different in folks who identify with a marginalized identity. So similarly, the environment elicits an emotion. The environment responds by ignoring that need. And the person is blocked from finding alternative pathways for getting needs met and feeling hopeless and helpless. So in this case, experiences of discrimination and structural stigma, such as the enforcement of policies at the state level that preclude people from getting medical care based on their identities, or that police language in schools about folks with certain identities as well, generates this feeling of helplessness in these populations. And the emotion itself is then paired with helplessness, and the person's relationship to the emotion is severely damaged. So anytime a person feels sadness or rejected, they also experience helplessness, and that helplessness leads to oftentimes not doing anything to change that emotion because there's no motivation to change what's going on in that environment. So consistent with this, I wanted to just present a study on minority stress and invalidation specifically. So I collected data from 320 sexual minority adults. All these adults were cisgender through Prolific Academic in August of 2023 this year. All participants passed validity checks, meaning we had sort of these 4 or 8 mock questions throughout the survey, and they had to pass at least 4 of them to be included in the study. And they also provided time probable responses. So they were taking at least 2 seconds to respond to each item. So we were pretty confident that these are not bots. Our demographics are pretty evenly split between cisgender men and women. It was predominantly white, and most participants did not identify as Latina. So some diversity issues there in our study. We had a very educated sample. About 86.3% of them had attended at least some secondary education. And because it's the US, despite employment rates being fairly high in our sample, about 42% of them made less than $31,000 a year. So now I want to take a chance just to talk through a couple of the measures that are going to be relevant for this. We have the perceived invalidation of emotion scale, which really assesses whether or not folks feel like others in their lives are invalidating the emotions or the feelings that they have. We also have the sexual orientation concealment scale, which measures intentional concealment of sexual orientation from others, which historically has been associated with poor mental health outcomes for sexual minority and gender minority folks. We also have the importance of gay and bisexual community activities scale, which really focuses on how involved are you within your community with folks with shared identity. And so this is something that traditionally has also been associated with more positive mental health outcomes for queer individuals. We have the abbreviated gay community stress scale, which is based on this theory of intra-minority stress, which is actually within gay communities and sexual minority communities. There are status hierarchies that afford certain people, depending on their identities, different social and sexual capital. And so if you're someone with low social and sexual capital, you actually experience a lot of stress within your own community. We have the HHRDS, which is essentially a measure of intergroup hostility. So looking at experiences of heterosexism, harassment, rejection, and things like that perpetrated against sexual minority folks. And we also have the internalized homophobia scale, which measures, again, the consequences of that intergroup hostility resulting in internalized attitudes that we have about ourselves. So these are some of the correlations that we had just to sort of set the stage a little bit. All of these minority stressors that I mentioned previously were associated with emotional invalidation positively. So as someone receives more minority stress in their environment or internalizes things more, they also report higher invalidation. Interestingly, we did not find any association between gay community involvement and invalidation, which is a little bit interesting. We thought that maybe it would be inversely related, but I think it actually probably makes sense, including gay community stress, that even being involved in the community may also not fully protect you. So in terms of differences across populations, we compared our sexual minority sample to a college and MTurk sample, which demonstrated that sexual minority folks are significantly more likely to report higher emotional invalidation, and that this is evidenced by a medium effect size. We also compared sexual minority men and women, and there are no differences between sexual minority men and women in terms of experiences of invalidation. So this sort of illustrates that when folks are in similar environments, those gaps get a lot more narrow in terms of the discrepancies between different populations and different groups. We then did a linear regression examining the effects of the minority stress variables on emotional invalidation. And what we found is when we look at these things simultaneously, that internalized stigma actually is not related to invalidation. Gay community stress is not related to invalidation, but experiences of intergroup hostility and sexual orientation concealment are positively associated with invalidation in sexual minority adults. And to just summarize this a little bit more for those of us who aren't like stats geeks, that we found like at the bivariate level in our correlations that all of these minority stressors are independently associated with emotional invalidation. But when we look at these things simultaneously and control for the effects of one another, we find that actually experiences of heterosexist discrimination and concealment are more robustly associated with perceived invalidation compared to other minority stressors. And specifically, to put this into perspective, if we have an invalidation pie and we were to take away a fifth of it, that's the amount of variance that sexual minority stressors are accounting for in experiences of invalidation in sexual minority adults. So the main takeaways that I want us to have from this talk today really focus on how we assess folks with marginalized identities for BPD and taking extra care and consideration when assessing sexual and gender minority clients for a variety of potentially severe diagnoses. It's important to consider the effects of minority stressors on emotional invalidation and BPD symptoms when we're conceptualizing our cases and the relationships between those two things, as well as treatment. So incorporating aspects of identity into the treatment, both strengths and stressors. So acknowledging that minority stress exists, as well as acknowledging a lot of strength that marginalized communities actually bring to the table. And if folks are looking for guidelines on how to adapt evidence-based treatments for this, John Pachankis has a really good 2023 article that gives 6 specific guidelines on how to adapt evidence-based treatments to be more responsive to the needs of sexual minority and gender minority adults. Huge shout out to my co-authors on this, my post-bac advisor, Tiffany Brown, who's actually an eating disorder researcher, but lets me do whatever I want. Katie Dixon-Gordon, who I'm sure many of you know, is my graduate advisor. And if you guys need to get into contact with us, we have our emails up there, our handles for a couple of social media sites, as well as the work cited. You can scan the QR code just to get references and things like that. So thank you all.
Right. Thank you so much for your talk, Dominic. That was wonderful. So we have a couple questions and I think more will be coming in. How do you determine the difference between fluctuating sexual and gender identities in teens as a normal exploration process versus the unstable sense of self that may come with BPD?
Yeah, that's a really good question. And so based on the existing literature, it's very normative to have fluctuations in how folks identify their sexual orientation or gender identity. And I think to pathologize that very normative developmental process of figuring out who you are is actually extremely misleading and potentially harmful for some clients, because everyone who is part of these populations experiences and goes on this journey. So it's a little bit weird, I think, to sit here and say, oh, well, it's an identity fluctuation instead of just normative development.
How much of the BPD prevalence in sexual and gender minorities is due to duplicated symptoms in BPD and gender dysphoria?
That is a great question. I think that we probably see a lot of overlap in these symptoms for both sexual minority and transgender and gender expansive individuals, especially the person's point who indicated these difficulties with identity, as well as the very common phenomenon of not really knowing who we are, or the common affective symptoms that accompany a lot of those challenging feelings and developmental concerns.
I have another question here asking, what resources would you recommend or steps for sexual gender minority individuals who believe they may have BPD?
Yeah, it's a great question. So I would say finding a provider who actually provides affirmative care. So a lot of times you can look on folks' websites or at the populations that they commonly treat. And these folks are definitely going to be very much attuned to a lot of the stressors that are associated with mental health in these populations that are a little bit unique. And that would be sort of my recommendation for just finding a provider in general. If you're someone from a marginalized community, is find someone who, you know, whether it be a sticker on their door that's like, this is a safe space, or as part of their actual mission statement and purpose for treating certain clients on their websites, I think is typically a good way to do it. And it's also perfectly fine to email providers and just be like, hey, I didn't see this on your website. Do you, service folks with affirmative care who have these identities? I think that that's perfectly fine and it's free. So do that.
Well, thank you for that answer. I think we have a couple more minutes still. I'm wondering if there's any note cards around with other questions. That seems, oh, maybe.
Question. Maybe this is like a little bit unrelated from your talk, but I'm coming from a background of studying sex differences in PTSD through like neuroendocrinology. So I was kind of wondering.
Give her the mic.
Oh, sorry. Sorry, I was just saying, I come from a background of studying sex differerences in PTSD through like neuroendocrinology. And so I was wondering, because hormones are a spectrum, just like gender, and I think there's recently been some neuroendocrinology research done in BPD. Like, has there been any sort of investigation of how hormones might be like playing some sort of biological role that like is leading to, different vulnerabilities for BPD and also diverse gender and sexual identities?
That's a good question. And I actually don't think that there's a whole lot of research on this within these populations. Again, like across the studies that I presented, there are only 17 that have examined BPD and sexual minority adults and gender diverse folks. And most of these have been self-reported, not really looking at psychophys data or hormone data in these populations. So I'm not sure, but I think that that's a really interesting question that someone with lots of money should investigate.
Okay, another question. What are 2 things you would ask clinicians to do to better serve sexual and gender minority groups?
I think a huge aspect of this is just being validating, right? We see that the presence of discrimination, harassment, things like that are super invalidating. And I also think that clinicians need to be a little bit more proactive and less scared of bringing up these topics with their clients if they express that they're a sexual or gender minority. A lot of times folks are a little bit resistant to sharing, things that aren't really a happy memory in their life related to an unchangeable characteristic that they possess. And so I think clinicians being a little bit more proactive and open to having these conversations and being responsive to whether or not the client wants to actually have that conversation is important. Because I think a lot of times folks are a little bit hesitancy coming into therapy regardless, and then matching that with an identity that has commonly been met with poor responses from other people. I think it's important that the clinicians really take on that task.
All right, a couple more questions. One person was wondering how you defined invalidation in your research and measured that.
Yeah, so the PI specifically is conceptualizing this as emotional invalidation. So the very common piece that we see in a lot of the models for BPD in terms of, you express your needs to someone and they don't meet your needs in return, or they invalidate you directly and say like, well, you should just stop feeling sad, or you should just stop feeling X, Y, and Z. And so that's what we were measuring in terms of the PIs. There are a couple of researchers who I've spoken to that are hopefully trying to create a measure of identity-related invalidation since it's qualitatively different. But I think functions very similarly, right? In the sense that people are invalidating something that you're bringing to the table. And in the case of a social identity, it's something that is not changeable. Even though emotions are somewhat transient at times, that's something that a couple of us are trying to work on across populations, not just within sexual and gender minority folks.
We have another great question asking, what can parents of sexual gender minority kids do to be more supportive?
Yeah. So again, I'll probably use the same response that I did for clinicians. I think having an open door policy with your adolescents to have these conversations and responding to what they actually express that they need and not necessarily what you think that they need. Because I think that that can also be an area where folks can be like, oh gosh, I didn't think I needed this from this person, but they're telling me and are trying to uh, to help me in some way that I don't feel like I need. Should I be worried about this? So I think, again, just more so letting the child lead and the patient lead.
Are there variations between the clinicians making the diagnoses, as in female versus male clinicians?
There were no differences in that study that I can recall that showed any bias in terms of the sex of a therapist providing the treatment. My thought would be that there are some studies that actually would indicate that female therapists tend to have more bias towards sexual minority adults. So there could be an effect. It just wasn't an effect in this study. And if it is, it was probably a very small one.
And then I think our maybe last question is it possible that the stress of discerning you might be a gay or sexual gender minority can be considered a trauma that might contribute to BPD?
Yeah, that's a good question. I think depending on what diagnostic system you're using, it probably wouldn't count as a criterion A, but that doesn't mean that it's important. I think that there are a lot of stressors, especially during the coming out process for sexual minority folks and gender minority folks that are inherently stressful because you hope that people respond in a way that is positive and it's not always met that way. So do I think that it's a trauma? My thought would be based on the current diagnostic systems, no, but that doesn't mean that it isn't important and real.